Good afternoon, students. Department of Occupational Therapy, and my today's topic is differential diagnosis of dyspeptic syndrome and abdominal pain, diagnosis and treatment of irritable bowel syndrome. Dyspepsia. What does mean dyspepsia? Dyspepsia describes symptoms such as discomfort, bloating, and nausea, which are thought to originate from the upper gastrointestinal tract. There are many causes, including some arising outside the digestive system, heartburn, and other reflux symptoms, are separate entities as they considered elsewhere. Also, symptoms often correlate poorly with the underlying diagnosis. A careful history is important to detect alarm features regarding urgent investigation and to detect atypical symptoms that might be due to problems outside the gastrointestinal tract. Dyspepsia affects up to 80% of the population at some time in life, and most patients have no serious underlying disease. People who present with new dyspepsia at an age of more than 55 years and younger patients unresponsive to empirical treatment require investigation to include serious disease. Causes of dyspepsia. It can be upper gastrointestinal disorders, peptic ulcer disease, non-ulcer dyspepsia, acute gastritis, gallstones, esophageal spasm, irritable bowel syndrome, other gastrointestinal disorders, peptic diseases, cancer, chronic pancreatitis, colonic carcinoma, hepatic disease, hepatitis, metastasis, systemic disease, renal failure, hypercalcemia, and drugs, NSAIDs, glucocorticosteroids, iron and potassium supplements, digoxin, others, psychological, anxiety, depression, alcohol. Alarm features in dyspepsia. This weight loss, anemia, vomiting, hematemesis or melena, dysphagia, palpable abdominal mass. This clinical examination of gastrointestinal tract. What we can find? Skin and nutritional status, pyoderma gangrenosus in ulcerative colitis. On the hands, we can see climbing in a patient with malabsorption. On the hand, on the neck, we can have glands in gastric cancer, atrophic glossitis and stomatitis and vitamin B12 deficiency. Abdominal examination. It can be multiple surgical scars, ileostoma and intracutaneous fistula in a patient with Crohn's disease. In the groin region, we can find hernia, lymph nodes. Investigation of dyspepsia. If the dyspepsia are the alarm features, it's no and age more than 55 years, endoscopy. If age less than 55 years, so test Helicobacter pylori, including serological and breast test. And then it's a positive Helicobacter pylori eradication, and is negative, treatment symptomatically or considered as a diagnosis. If a patient with dyspepsia has alarm features, so it should be urgent endoscopy. Malabsorption. Diarrhea and weight loss in a patient with a normal diet are likely to be caused by malabsorption. The symptoms are disturbed in nature and variable in severity. A few patients have apparently normal bowel habit, but diarrhea is usually and may be by water or voluminous, pale and offer a stool that floats in the toilet statorrhea, signify fatty malabsorption. Abdominal distension, purgatory, cramping, weight loss, and undigested food in the stool may be present. Some patients complain only of malaise and lethargy. In others, symptoms related to deficiency of specific vitamins, trace elements, and minerals may occur. Possible physical considerations of malabsorption. If a patient has deficiency of B12 vitamin, it can be anemia, it can be peripheral neuropathy, and stomatitis glossitis. If the patient has vitamin A deficiency, night blindness, follicular hyperkeratosis, its deficiency of vitamin D, osteomalacia, rickets, muscle wasting, proximal myopathy, and others. In this picture you can see deficiency of vitamins. Malabsorption results from abnormalities of the three processes that are essential to normal digestion. It can be intraluminar maldigestion, mucosal malabsorption, and postmucosal lymphatic obstruction. Intraluminar maldigestion occurs when deficiency of bile and pancreatic enzymes results in anaborative solubilization and hydrolysis of nutrients. Fat and protein malabsorption result. This may also occur with small bowel bacterial overgrowth. Mucosal malabsorption results from small bowel resection or considers that damage the small intestinal epithelium, thereby benionization the surface area for absorption and a blatant brush over enzymes activity. Postmucosal lymphatic obstruction prevents the uptake and transport of absorbed lipids into lymphatic vessels. Increased pressure in the vessels results in leakage into the intestinal lumen, leading to protein losing and enteropathy. Investigation for susceptible malabsorption. Susceptible malabsorption. It's a clinical features of steatorrhea, blood test, urea and electrolytes, immunoglobulins, calcium, magnesium, full blood count, clotting, albumin, folate, B12, celiac antibodies. Investigate small intestine, duodenal biopsy, barium studies of small barium MRI, fecal calprotectin, lactose, glucose, hydrogen breast test. It's an normal. Investigate pancreas functional test, faces elastase, ultrasound, scan CT, MRCP. Normal. Consider bile salt malabsorption, scan, and serum 7A hydroxycholesterol. Abdominal pain. There are 4 types of abdominal pain: visceral, parietal, referent pain, and psychogenic. Visceral. Gut organs are intensive to stimuli such as burning and cutting, but are sensitive to distension, contraction, wasting, and stretching. Pain from unpaired structures is usually, but not always, felt in the midline. Parietal. The parietal peritoneum is undernerved by the somatic nerve and its involvement by inflammation, infection, or neoplasia, necrosis, sharp, well-localized, and lateral pain, red pain, gallbladder pain, for example, may be referred to the back or shoulder tip. Psychogenic. Cultural, emotional, and psychological factors influence someone's experience of pain. In some patients, neurogenic causes can be found, applied investigation, and psychogenic causes, depression or stimulation disorders may be responsible. The acute abdomen. This accounts for approximately 50% of all urgent admission to general surgical units. The acute abdomen is considered of one or more pathological processes: inflammation, perforation, and obstruction. Inflammation. Pain develops gradually, usually over several hours. It is initially rather diffuse until the parietal peritoneum is involved, when it becomes localized. Movement exacerbates the pain, abdominal rigidity, and growing occur. Perforation. When viscous perforates, pain starts abruptly. It is severe and leads to generalized peritonitis. Obstruction. Pain is colicky, with spasms that cause the patient to ride around and double up. Colicky pain that does not disappear between spasms suggests complication inflammation. Causes of acute abdominal pain. Inflammation. Appendicitis, diverticulitis, cholecystitis, pyelonephritis, pelvic inflammatory disease, pancreatitis, intra-abdominal abscess. Perforation and rupture. It can be a cyst, peptic ulcer, diverticular disease, aortic aneurysm, obstruction reasons. Intestinal obstruction, biliary colic, with rectal colic. Extraintestinal causes of chronic or recurrent abdominal pain. It can be retroperitoneal, it can be aortic aneurysm, malignancy, lymphadenopathic abscess, psychogenic, depression, anxiety, hypohidrosis, somatostatin, locomotor, vertebral compression fracture, abdominal muscle strains, metabolic reasons, endocrine, diabetes mellitus, acute intermittent porphyria, hypercalcemia, hematological reasons, sickle cell disease, hematological disorders, neurological reasons, spinal cord lesions, taped results, radiculopathy. Management of acute abdominal pain algorithm. If a patient has a pain and present symptoms and signs of peritonitis, it should be resuscitation and laparotomy. It's no clear evidence of peritonitis. First, blood test. If it will be increase of amylase lipase, it's acute pancreatitis. It's no diagnosis, chest X-ray, as we can find free air perforation reason. No airfare abdominal X-ray, dilated lobes of bowel, intestinal obstruction. No abnormality, ultrasound, gallstones, it can be cholecystitis. No abnormality, contractile radiology. Abnormality detected, it can be perforation of septal obstruction. No abnormality, CT scan. Abnormality detected can be pancreatitis, abscess, aortic aneurysm, malignancy. And no abnormality, it can be symptoms self-observe or symptom persist, so laparoscopy. Irritable bowel syndrome. Irritable bowel syndrome is characterized by recurrent abdominal pain is associated with abnormal defecation and the absence of a structural abnormality of the gastrointestinal tract. About 10–15% of the population are affected at some time, but only 10 of those consult their doctors because of symptoms. Irritable bowel syndrome is the most common cause of gastrointestinal failure and occurs for frequent abstinence from work and impaired quality of life. Young women are affected 2–3 times more often than men. Coexisting conditions such as non-ulcer dyspepsia, chronic fatigue syndrome, dysmenorrhea, fibromyalgia are common. IBS is sometimes associated with a history of physical or sexual abuse, and it is an important aspect as a history as those patients different from psychological-based therapy. Rome criteria. Rome's 3 criteria for diagnosis of irritable bowel syndrome. Recurrent abdominal pain or discomfort on at least 3 days per month in at least 3 months associated with 2 or more of the following. Improvement with defecation, onset associated with a change of frequency of stool, or onset associated with a change of form appearance of stool. And supporting diagnostic features and alarm features in irritable bowel syndrome. Features supporting diagnosis of IBS. Presence of symptoms more for more than 6 months. Frequent consultation of non-gastrointestinal problems. Previous medically unexpected symptoms. Worsening of symptoms by stress. Alarm features. Age more than 50 years and male gender. Weight loss. Non-structural symptoms, family history of colon cancer, anemia, rectal bleeding. Investigations. The diagnosis is clinical in nature and can be made confidently in most patients using the Rome criteria, combined with the absence of alarm symptoms, without resorting to complicated tests. Full blood count and fecal calprotectin. Without sigmoidoscopy are usually down and are normal in IBS. Colonoscopy should be untakeable in older patients over 40 years of age to include colorectal cancer. Endoscopic examination and as required in patients who report rectal bleeding to include colon cancer and IBD. Those who present typically require investigation to include other gastrointestinal diseases. Diarrhea predominant patient. Just the investigation to include celiac disease, microscopic colitis, lactose intolerance, bile aciduria, thyrotoxicosis, and developing countries parasitic infections. Management. Dietary management of irritable bowel syndrome. Eat regular and avoid missing meals. Take time to eat. Ensure adequate hydration and avoid carbonated and suffocating drinks. Reduced alcohol intake. Reduced intake of resistant starch and insoluble fiber. Avoid foods with artificial sweetness. Consider a wheat-free diet. Consider a lactose inclusion diet. Consider a diet low in fermentable omega-3 and monosaccharides and oils. Management for constipation predominant. Higher phage diet, psyllium, lactose, and omega. Symptoms persist. It can be duloxetine, 60 milligram at night, relaxation therapy, biofeedback hydrotherapy. It's a presenteria predominant, antidiarrheal drugs, loperamide, codeine phosphate, cholestyramine. Symptoms persist. Patient can add amitriptyline or epinephrine, rifaximin. It's a pain and bloating syndrome. Spasmodic drugs, mebeverine, peppermint oil, doscidine, probiotic, rifaximin, amitriptyline at night. So thanks for your attention.